Well, greetings. My name is Andrew MacPherson, and I'm managing partner at Healthsperian LLC, a Washington, D.C. based health policy consulting firm, and I'm the founder and co-director of the Coalition to End Social Isolation and Loneliness. I'm absolutely thrilled to introduce you to today's discussion, a spotlight on social isolation. Founded in 2018, our coalition's mission is to engage diverse stakeholders, promote innovative research, and advocate for federal policy change that combats the adverse consequences of social isolation and loneliness, and advance approaches that improve social connectedness for all Americans. Our vision is that all Americans have the opportunities and supports necessary to be socially engaged in society. Our members include consumer groups, health plans, health systems, providers, employers, community-based organizations, and tech innovators. We are enormously grateful for the support and the engagement of the Better Medicare Alliance and many of its allies. Thank you so much for your collaboration. We are also honored to moderate this important panel session today. So with that, let me introduce you to our distinguished speakers. Dr. Charlotte Yeh is the Chief Medical Officer for AARP Services Incorporated. In her role, Dr. Yeh works with the independent carriers that make health-related products and services available to AARP members to identify programs and initiatives that will lead to enhanced care for older adults. Dr. Yeh has more than 30 years of healthcare experience as a practitioner and chief of emergency medicine at Newton Wellesley Hospital and Tufts Medical Center, as the medical director for the National Heritage Insurance Company, a Medicare Part B claims contractor, and as the regional administrator for the Centers for Medicare and Medicaid Services in Boston. Dr. Yeh is widely recognized for her commitment to and passion for the healthcare consumer and has received numerous honors and awards for her efforts on behalf of patients. As a healthcare leader, she has served on numerous boards and committees throughout her career. She's also a member of the Advisory Council for the National Institute on Deafness and Other Communicable Disorders, the Personal Connected Health Alliance Board of Managers and Board of Directors for the Schwartz Center for Compassionate Care. Welcome, Dr. Yeh. We're honored to have you with us today. And Bob Blancato. Bob Blancato is the president of Matz Blancato and Associates based in Washington, downtown Washington, D.C. In this capacity, he also serves as the national coordinator of the bipartisan 3,000-member Elder Justice Coalition, the executive director of the National Association of Nutrition and Aging Services Programs, and the national coordinator of the Defeat Malnutrition Today Coalition. Bob has long been recognized as a national advocate with policy expertise on behalf of older adults. In 2019, he was invited by both the Senate Finance Committee and the House Ways and Means Committee to testify on a range of issues. Bob's prior work history includes 17 years as a staffer in Congress and an appointment by President Clinton to be the executive director of the 1995 White House Conference on Aging, one of 4 he has participated in since. As a volunteer, he currently serves on the National Board of AARP and the board of the National Hispanic Council on Aging. In 2019, Bob began a 4-year term on the National Advisory Committee on Rural Health and Human Services, appointed by HHS Secretary Alex Azar. He holds degrees from Georgetown and American University, and he's won numerous awards for his advocacy. But most importantly, perhaps most importantly, Bob was absolutely instrumental in standing up and helping build and launch the Coalition to End Social Isolation and Loneliness in 2018. I'm personally very grateful for all of his guidance and support in doing so, and we're thrilled to have him join our panel discussion today. So with that, we're going to turn to our panel speakers for opening remarks, and then we'll have a discussion, a fireside chat together. So with that, I'm going to turn to Dr. Charlotte Yeh for her opening remarks. Dr. Yeh.
Thank you. Thank you so much, Andrew, for the kind introduction, and I'm just delighted to be here. So I'm sure, as many of those in the audience, many of you are probably as passionate as Bob and I are about social connection, social isolation and loneliness. And certainly we've all lived through the pandemic, and we all understand what it means to be socially disconnected from our friends, our family, from work, our community. So if nothing else, it is a more powerful topic than ever. But as passionate as we are, we can't really make a dent or make a difference. I know many of the audience, whether you're coming from health plans, whether you're health providers, whether you're innovative companies, whether you're working in operations, strategy, or policy, and you know the power of social connection, whether in your workplace, in your workforce, or in your community with family, we can't make this move. We're not going to get the kind of attention if we don't create the kind of investment, instead of going out and begging for grants and money here, there, which are all really, really important to get the research and the data and the impact it has on health, is not enough unless we create a reason that this is not just a nice to have, but a must have. We are very human. It is very powerful to our health and healthcare outcomes. So what is the business case that compels us to invest in a sustainable way? So I thought the way I would open is maybe share a story of collaboration, since you are the coalition and it's all about collaboration, between AARP Services, the business subsidiary of AARP, and United Healthcare that handles our AARP branded Medicare plans. So a number of years ago, we started healthcare transformation and said, could we do a collaboration where we take the assets of the consumer, understanding that AARP has, and work with one of our vendors, i.e. United Healthcare, that understands healthcare financing and delivery, and could we not transform healthcare in a way that's meaningful? Can we improve the outcomes? Can we improve the experience of care? And can we improve the affordability? Well, you can't start on such a project if you're not saying, where are the opportunities and the gaps? So we did a number of things from care coordination, but interesting, we chose to operate in the fee-for-service world because it is a pure consumer model where it doesn't matter which provider you see, but could we change thinking and behavior by looking and understanding who is this consumer, how do they engage, how do we get behavior change? And as we looked across the board, and we worked mostly in our Medicare supplemental plan area, the striking thing, and I'm sure many of you who are in healthcare like me, I'm an emergency physician. I saw a lot of healthcare. I saw all the flaws, whether it's healthcare or the community, because they came in through the emergency department. We said, where are the opportunities? Well, we've all seen people that we look on their claims and we look at their history and we go, oh my goodness, they have all these chronic conditions, they have all these terrible things. And I've got Mary and I've got Jane, and they look identical on the health claims. And then we say, gee, they even come from the same zip code. So they have the same access to transportation, education, income, food security, all the things that are really, really important also to health. And yet somehow, here's Mary, who is thriving, out and about, volunteering in the community. And here's Jane, who's on her last legs. And yet on paper, they looked identical. And we said, how are they so different? Or as an emergency doc, someone coming in with a hip fracture in one room at 80 years old, I know she'll walk out. In the next room with the identical fracture, I know it's the end of the road. What is the difference? And so we said, here's an opportunity gap. Can we go after the thrivers instead of going after the failure to thrive? So fast forward a few years, we studied a variety of things, and we came down to the conclusion is that it has to do with resiliency. It has to do with your ability to cope and adapt. And it turns out you can't cope and adapt well so without people and community and social support around you. So fast forward again, and as we looked at aspects of resiliency, we actually published a paper to say we looked at 5 factors: purpose, resiliency, optimism, social connection, very important, and locus of control. And it turns out, and these are correlations, I can't tell you they're causal, but it turns out that it didn't matter which one you had, but the more you had, the less self-reported depression, the less self-reported anxiety, the less self-reported fair and poor health, the less self-reported functional limitations. And we said, wow, this is kind of interesting. It's very dose response. More importantly, if you looked at the cost side, because I know everyone cares about the money, and this is the business case, if you will, For every one of those added factors, we save $1,356 per person over a year. So imagine the opportunity gap we have right here. So about 20% of our population had no protective factors, no resiliency, no bounce back capability. And if you have about 4 million members in our Medicare supplemental plan, that means 800,000 have no resiliency. If we just gave them one factor, say social connection, the ability to have friends and family and community support you, we're talking a potential $1 billion in savings. And even if we could only fix 10%, that's still 100 million. So as we looked and we said, you know, what's meaningful and resilient, there are many, many factors. So we looked at 3: purpose, optimism, or a positive perception of aging, and we looked at social connection. So I'll start with purpose. It turns out if you have a strong sense of purpose, you have fewer, more preventive services, fewer strokes, better sleep, lower cholesterol, and fewer nights in the hospital, fewer doctor visits, and most interesting, about 35% of our population were low in purpose, and they cost us 12% more PMPM. So when you think of outcomes and you think of affordability, what matters to the business community, this resonates. And in the business world, we know if you have a strong mission and a purpose, you actually are more likely to recover when there's negative news or bad news about your company. There's still, the population and the public is still likely to think positively of you. You're more likely to have higher margins. You're more likely for people to remember your brand name. So we also looked at the second factor, which is also meaningful and modifiable, which is the perception of aging. We live in a very, very youth-oriented culture. And it turns out that if you have a positive view of aging, and it's not just about decline, you have 44% more likely to recover from disabilities. You have less cardiovascular disease, less dementia, less strokes, 55% fewer nights in the hospital. And in our population, and again, a correlation, there's about 40% who have a negative view of aging, and they cost 33% more per member per month in healthcare dollars. And what is really sad is that AARP with the University of Michigan, had done a study to show that already a third of people 50 and older believe that loneliness and depression are inevitable with aging. And if we don't change that thinking and that behavior, we're not going to get behavior change. So the last, which is the topic of isolation and loneliness, is the power of people, of social connection. And many of you already know the health-related factors, 32% higher risk of stroke, 29% higher risk of cardiovascular disease, 26% higher mortality, the risk factor of half a pack of cigarettes a day, 8 years off the end of your life. And for those of you who are in healthcare, and this is really important because, again, where is the business case that this is not just nice to talk about, but a must-have? It turns out that we published it back in 2015, that the single biggest predictor of dissatisfaction with healthcare, think about NPS, provider scores, that the single biggest predictor turned out to be loneliness, more than health literacy, more than depression. And yet in 2015, we never talked about it. So we have been diving deep into this, and we have identified that, in fact, about 40-some% of our population is lonely, mostly moderate, but 19% are severely lonely. And by the way, they cost us 20% more per member per month. And AARP looked at social isolation. So in the health plan side, we look at loneliness, which is subjective, how you feel about it. Social isolation is the size of your network. It is a more objective measure. And even with social isolation, it costs us $6.7 billion in Medicare spend. So when you step back and say, this is not a nice to have, this is a must have. If we want to improve outcomes, if we want to really reduce affordability, working on the healthcare delivery system, social determinants are very, very powerful, but we also have to work on these personal determinants, the sense of resiliency and social connection. And in fact, AARP has a study that showed the more friends you had, the more healthy behaviors, again, in almost a dose response way. And if I were to take this a little bit further, because you say, oh, this is great. Now we have been testing a variety of interventions, and we know that you can intervene. We know that there are, whether it's digital apps, whether it's community programs, whether it's volunteerism, we know you can shift the needle and improve social connection and improve well-being. It's going to take a little longer to look at the impact on health outcomes. But I have to say there is one subsegment that we have totally ignored that is a huge, especially for older adults that face social isolation and loneliness, and that is that silent epidemic of hearing loss. Do you know about 40% of 60 and older have clinically significant hearing loss? 2/3 of 70 and older have clinically significant hearing loss. And it turns out that uncorrected hearing loss is the single biggest risk factor for avoidable dementia. This was by the Lancet Commission on Dementia. And we also did a study looking at tracking people over 10 years with large observational data studies. And it turns out that if you go 10 years without correcting your hearing, which is very, very common, most people do not get hearing aids, it turns out you have a 52% higher risk of dementia. You have a 41% higher risk of depression, 29% more falls, 46% higher healthcare costs. That's $22,434 per person. So think of 2/3 of 70-year-olds who never get their hearing taken care of. 47% more admission rates, 44% more readmission rates. So it's a huge impact on outcomes. And there's actually a study out there that took European data, translated it to the US, and that costs us about $133 billion of uncorrected hearing loss. So, and the saddest part to me is this is totally fixable. With hearing aids, rehabilitation services, helping people with speech comprehension, captioning, on your video chats, your video conferencing, wearing masks where you can see the face, these are fixable right now, here and now. And by the way, recently the FDA just came out with its over-the-counter hearing aid regs, so we might be able to adjust affordability. And to me, it is so sad that one of the biggest causes of isolation, loneliness, and a risk factor for dementia, we don't talk about, and yet intervention exists. So moving ahead, I hope what I've shared with you is if we want to make a difference in social connection, we have to make the case. It is not good enough to say it makes me feel better, but we can also show it impacts our outcomes. We know that it is very important to experience, to satisfaction, to engagement in your behavior. Thirdly, we know that it costs us money if we fail to address it. And that's my hope, is that we will continue the kind of research, the policy, and the investment to make our lives better. We learned this in the pandemic, and surely we can make this into a silver lining. So thank you.
Excellent. Thank you so much, Dr. Yeh. The purpose, possibilities, people, but connecting that to the business case, just critically important when we're thinking about, supporting individuals across the country, especially older Americans who are isolated and or lonely. Thank you so much for those opening remarks. Really excited for the discussion. With that, we're going to turn to Bob Blancato for his opening remarks. Bob.
Andrew, thank you very much for a great introduction. Congratulations to you on the leadership of the coalition. Somebody can always found it, but somebody's got to lead it. You've been leading it, done a great job. I want to thank BMA for listing this session in their summit. I think it's important that they spotlight this issue. I'm proud our NANES group is an ally of BMA and has been for a long time. A special shout out to my friend and colleague, Mary Beth Donahue, and her new leadership of BMA. And Robin, thank you for your help here. And of course, Charlotte, who is just a legend in her own right. It's great to be with her too. So, we talked about the pandemic, and, we know how it's exacerbated the issues of social isolation and loneliness to a whole new level. Before the pandemic, we were dealing with a growing national concern. Today, we're dealing with a full-fledged public health emergency, and we have to start acting like it is. And, the spotlight on social isolation that we're doing here, I got to point out that Medicare Advantage has done its part to some degree through their supplemental non-medical services to address some of those very issues. But to understand it from a policy perspective, as we talked about before, we've got to look at the linkages between social isolation and loneliness. the linkage between elder abuse and social isolation and self-neglect falls, malnutrition, mental health with anxiety and depression, cognitive decline, and a 50% increased risk of dementia. Social isolation is an equity issue. Issues such as housing, inadequate segregated housing for long periods of time, inaccessible transportation, which hinders more social opportunities. The digital divide, which I know we talk about a lot, how it hinders social connectedness, whether it's through simple reassurances, wellness checks, or telehealth. And of course, poverty and inadequate income contributes to social isolation. Commonwealth Fund stated that 40% of high need isolated adults have incomes below $15,000 a year. So we are seeing things being done. Progress is being made. The coalition's had a lot to do with it. We talk about the Older Americans Act as a good example. In its 2020 reauthorization, it called for first-time screening for social isolation. And it is now, it was proposed actually by a rural area agency director who said, why don't we have it? And sometimes advocacy can be just by asking those kind of questions. And then, you know, I've been very involved with the Older Americans Act nutrition program. Many of you know Meals on Wheels. But before the pandemic, 2/3 of older adults were getting their meals in congregate settings with social connectedness on a daily basis, okay? 2/3. Now, 98% of people are getting their meals at home, oftentimes by themselves. So we need, as one of our solutions, to bring the congregate program back in a safe way so we can continue to promote socialization in that one setting. And we need to get those things done well. Pending in Washington right now, and we're going to talk, I know, a lot about this in our Q&A, is this whole big Build Back Better legislation. But contained in this massive bill is a very important initiative called the Elder Justice Reauthorization and Modernization Act, which would provide $4 billion to build an infrastructure for elder justice. Things that you would expect, like adult protective services and a long-term care ombudsman program. But also a new grant program for area agencies and other community-based organizations to conduct outreach and to individuals at risk of social isolation, to develop community-based interventions to mitigate social isolation, and connect at-risk individuals with social and clinical supports. And also HHS has to establish programs to provide and improve training for area agencies and other CBOs to address and prevent social isolation. This was based on important legislation that Senator Smith and Congressman Sanchez introduced at the urging of the coalition, as I recall. Now, you know, there's a lot of other big issues that are pending in this bill that's pending in Washington. You've got a broadband. You know, infrastructure has now been defined to include broadband finally. It isn't just about highways and roads and bridges, it's about broadband, which it should have been a long time ago. But it's going to become important at the local level how you implement when you get that money for infrastructure to make sure you commit the necessary resources to broadband. Also, the expansion of Medicaid home and community-based services, okay, something that we're all very concerned about. 820,000 people on a waiting list, okay? And think about how many of those people are isolated and lonely because of that status of being on a waiting list. And we can also look at this as a new way of creating jobs. 500,000 new jobs could be created if we expand home and community-based services. We have the expanded Medicare benefit possibilities, dental, vision, hearing, all of which can contribute to social connectedness if they're allowed to be in Medicare fee-for-service. And, you know, there are a whole lot of things that we'd like to see in this bill. You know, we also know that in response to the coalition and the issue itself, there's now a social determinants of health caucus in the House of Representatives that's been looking at this issue for some time now. And, you know, we want to see there be more work done to keep raising this issue. I think what we really need to be thinking about doing, a very simple step, and I know the coalition has called for this, we need an inventory. What is out there now that could fall under the category of a program that's trying to address social isolation? Sometimes you can learn a lot of things by doing inventory. You'll find out that there's fragmentation. You'll find out that you cannot connect these dots unless you know who you're connecting with. So let's hope that we can, as part of our ongoing activities, do that inventory, find out what we have, what we're doing, and go from there. And I look forward to our discussion and look forward to our questions. Andrew, thank you very much.
Excellent. Thank you. Thank you so much, Bob. And, you know, we can't thank also the Elder Justice Coalition enough for its leadership, not just on the broader reauthorization, but language that you referenced with respect to community-based organizations across the country supporting older Americans that are isolated and lonely. So thank you. Let's dig in on that a little bit, Bob, together. Let's look at the political sort of tea leaves here. Are we really going to get this done? We've got an October 31st deadline, that a self-imposed deadline that the majority leader has set. You've written about this recently, excuse me, in Next Avenue, for example. Are we going to be able to get this package done? And what does that mean even beyond social isolation, the social isolation provisions for people who are isolated and lonely across the country?
Well, I'm going to believe the answer is yes, but it's not going to look anything like it started. I think that's how you have to look at this. I think you're dealing with the incredible shrinking BBB, as we call it. I mean, 3.5 trillion was an aspiration. Okay. 1.5 trillion is a marker. Okay. That's the low number that Senator Manchin has deemed to be where he would go from. In the article I wrote just yesterday, actually, my feeling was the number will be somewhere in between. And then this morning, the papers are reporting that the president may be under 2 trillion in his agreement. So with that as an understanding, the top line determines what stays and what goes, what you can afford and what you can't afford. And that's where advocacy comes into play. Okay. I mean, the people who are really passionate about something and can understand and localize and humanize the issue and connect the dots. Home and community-based care is about reducing social isolation. So you're going to have to pitch your arguments as broadly as possible and show the political imperative associated with an issue. Anybody can talk policy, but you have to talk politics to actually get policy done, because there's no good policy without politics. So now you've reached that level where people who are engaged in this conversation, of which there are many people engaged in this conversation, have got to determine what their priorities are, what they're willing to accept as a smaller arrangement, okay? And then go to work and make sure you come out with something. So in our case, with the elder justice thing, it's a $4 billion 4-year commitment. That's not going to probably hold up. However, we know that, we can talk about what can be acceptable. It's still new money. It's still important money. And we will hold on as firmly as we can to the social isolation grants because they are historic in nature. They could be huge with an impact. And that's the other thing you have to stress. What's the impact going to be? Okay. Charlotte talked very well about the preventative side of things. If you start adding hearing and dental and vision, okay, there's prevention associated with that. Elder abuse prevention, it's the words we have to focus on. So we're at a really critical juncture. I don't know whether or not it's going to be a trick or treat on Halloween at the end of this month, but we'll see soon.
Excellent. And thank you, Bob. And I think about Bob's comments and all the different opportunities, Dr. Ye, in this reconciliation, this really historic, potentially reconciliation vehicle on the Capitol Hill. There's numerous efforts, of course, with this administration as well. Medicare Advantage seems to be growing by the day. I don't think it's ever been more important to make sure that we're learning from the evidence base that you talked about and learning from the pilots and learning from the data that we're seeing with health plans and also providers across the country. Comment on how we make sure we get this right, that we are learning from the evidence base, that we're seeking policy interventions and making sure we support Medicare Advantage plans in a way that we're sure works, that will actually help people who are isolated and or lonely.
Yeah, exactly. So I love the fact that Bob talked about the policies and, more importantly, the politics to get this done. I like to say you have to buttress that with getting the business community also invested. Yep. Because it's not just prevention because it feels good and, great, I live 8 years longer because I solved for loneliness, but it's that it has the potential of us saving real dollars. Imagine that if we could address loneliness and save 20% PMPM in dollars, that's the opportunity. Imagine if we just in Medicare alone could save 6.7 billion because we've addressed social isolation. Imagine if we addressed hearing, a profound loss of communication with people, profoundly connected to social isolation and to loneliness, 133 billion. There is more than enough money in that to cover elder justice, to help to make sure that our elders are well taken care of, to make sure that people can have accessible and frankly affordable health care. So so my ask of you is, we've done some of this early data. We are seeing the correlations. I think it is time, whether you're a healthcare provider system, whether you're another health plan, whether you're Medicare Advantage, whether you're Medicaid, is you should start tracking your members, your patients, your caregivers, and your families to actually begin to track and identify these data, just like you track BMI, just like you track their hemoglobin A1C. You should be tracking isolation, the objective number. You should be tracking subjective, the loneliness, and following that and beginning to test interventions. And then through the coalition, as Bob said, we can then create the inventory, and then we can find the shared, because there is no one size fits all. And we know that treating isolation is very different than treating loneliness. The only thing I also ask is, and this is coming from a physician, the only thing I really ask is we do not medicalize this. This is really humanizing. And it is to remember that we are all human, and it is about living well, and it's about living our 100-year life. It is not about, can I treat your heart disease?
Andrew, can I throw a point in? It's a very good point that Charlotte made, but, as the sports person you are, Andrew, in this environment, we have to play offense and defense at the same time, okay? We know what we have to do on the offense side, but on defense, let's talk about two things in particular. One, and I said this in this article, I am concerned about the pitting of children issues against older adult issues, which is happening. There is no reason for that. There's room to accommodate all, okay? And people have to talk about that very openly and honestly, okay? And number two is this whole question about, making improvements to Medicare at the expense of Medicare Advantage makes no sense, okay? Medicare Advantage has proven its worth in many ways. It serves lower income individuals. It serves more minorities than fee-for-service does. And the non-medical supplemental services have been the game changer in many ways. So, there's got to be the proper balance. You don't take from one from the other, especially if it's working. So let's keep that in mind in our discussions going forward.
I think it's a critically important point. And as you both were saying, you think about the really extraordinary changes that we're seeing in Medicare Advantage. We're seeing plans innovate. We're seeing new partnerships occur in communities across the country with health plans and community-based organizations. Dr. I think about your extraordinary background as a clinician, as a policymaker, and now a consumer business leader. How do we create those partnerships to address isolation and loneliness? How do we ensure that we don't over-medicalize this issue? I think at our coalition, we found that Medicare and Medicaid are great places to start, and they're great levers that we can of course push on in the public programs. But we don't want to over medicalize this. The reality is a lot of the interventions are social determinant in nature or social support in nature. Talk about when you wear your clinical hat, what that sort of looks like in practice.
So the answer is, on a clinical basis, loneliness is really real. And I'll just tell you one little story from the emergency department. I'm, running the emergency department, running around, and one of the residents comes in and says, "Oh, Charlotte, I've got this old guy, sitting there. He's complaining of shortness of breath. He's had it for 2 weeks. Oh my God, we have done this scan, this blood test. We have done every test in the book, and they're all normal. So I think he's just a malingerer, and can I just kick him out of the emergency department?" Okay. And I'm going, whoa, wait, can I just go in? Let me go talk to him. I walk in the room, and the first thing I did was said, "Are you sad?" I took one look, and he bursts into tears. And it turns out that 2 weeks ago, when his shortness of breath started, he had lost his partner of 20 plus years, and frankly was grieving and was lonely. And, there are so many who can't say, "I'm lonely." No one wants to wear that big L on your forehead. And so what does he do? He comes for help by saying, "I'm short of breath." We now spent, I don't know how many thousands of dollars on tests, when all it took was, "I know how you feel. You're not alone. Let me put you in touch with people who have been through what you have." So this is why, if you don't measure it, You don't study it, you're not going to discover it, and we're just going to be shelling out more and more money in the healthcare when in fact these are solvable problems. A hearing aid,
Andrew, I have to say that Charlotte told you one story. I'll tell you another story, a little more positive in its tone, but it tells the same story. And I talked about the Older Americans Act Nutrition Program, the congregate side. All right, I'm in Fort Wayne, Indiana, doing a visit. I'm trying to find out for the people who come to the program, what's the main reason that they come? And I'm sitting at a whole room, about 90 older adults. About 90% of them said, we come for the socialization, right? Now, if you ever go to a congregate nutrition program, they all sit together at the same table every day, like it was third grade all over again. And there's always a ringleader at every table, right? So this one woman hadn't said a word. And I said, okay, ma'am, before I move to the next table, what's the main reason you come here? She said, well, first of all, young man, I have to trust you. I said, okay, let's get past that. Second of all, she said, no, the main reason we come here, to gossip. That's socialization. That's putting people together. Those little things like that. We should support those programs that are already doing this. And there are many of them out there.
And the interesting thing, oh, so sorry, Andrea. I wanted to build on what Bob had said earlier, pitting children against adults. So we know that resiliency, and helping kids socialize, is makes a huge difference in their long-term education, their long-term career growth, their long-term income, assets, financial resiliency, let alone their health. Well, if you missed it in childhood, why should you not get it when you're 40, when you're 50, when you're 60, when you're 85? We know a 10-year-old today has the potential of living to 104 years old, a 50-50 chance.
Yes.
We should be planning that 100-year life, and we have the resources if we invest it wisely.
These are extraordinary stories and terrific ideas. Bob, it strikes me that everything I just heard is bipartisan, maybe nonpartisan. How do we make this a bipartisan issue? How do we talk to both sides of the aisle and bring them together to focus on supporting this population, as Dr. Ye said, going at the stigma of loneliness in this country? How do we make it bipartisan?
And that's the tricky part, because so many things that should be more bipartisan are not at the moment. And sometimes it has to do with larger issues than the one you're talking about that cause that. But I still believe that there is fundamental belief that if you localize and humanize an issue to an elected official, they'll get the point. They'll see it. They have to see it. They have to know what it is. They have to get an idea. Who's it affecting? And I know that members of Congress who have had family members with certain diseases have raised tons of money in appropriations for that disease because they can tie the story personally.
Yes.
This one is not so amorphous. People think it's amorphous to talk about social isolation and loneliness. It isn't. It's happening everywhere. All right. And so what you got to do is get those stories into the mainstream of conversation so that when you are approaching this issue from a solution standpoint, you benefit politically. Okay, and that's what it's about. They want to have the stories, but they want to get patted on the back for doing the right thing. So you have to put them both together, and that's how I think we'll get there.
Yeah, I think we have an extraordinary opportunity because we've lived through this pandemic. I don't know anyone who has come through, who hasn't felt stress, who hasn't felt anxious because they couldn't see their family, because they couldn't go to the hospital, because they couldn't visit grandparents, whether they're in a retirement home or in their own home or in the community. You can't visit friends, you can't have weddings, okay? This is something that touches every single person. Talk about equity. This is across the board, no matter what community or population you come from. So if there's anything you can gather around, it has to be this. But the second thing I wanted to say is it doesn't have to just be politics and policy. That's critical. And Bob, please do not stop working on the coalition. Please don't stop. So this is not meant, but I am really struck of the opportunities we're missing to change the narrative. So for example, do you know that media images, marketing images, even health plans, providers' images are 7 times more likely to be negative for people over 50 than under 50. 28% of the advertising in media is negative compared to 4%. Now, what do I mean by that? Just take a look at watching the media. You are more likely, if you're an older adult, to be seen alone. You are more likely to be seen just in the home with family and friends, and yet many of us are still working, not only in our 50s and 60s, but into our 70s and more. and you never see them with coworkers in the workplace. And you're more likely to be seen as dependent, that you're sitting with somebody showing you how to do something because, oh, you must not know how to do it, or being shown as dependent, seeing a physician. If we don't change those images, we will continue to perpetuate that you're lonely and old. And in fact, this same AARP and University of Michigan survey that I mentioned, if you watch 4 hours more of streaming and media, you are more likely to internalize this negative view of aging. So one of my favorite examples is I'm in the Boston area, that the city of Boston changed the name of their Commission for Elder Affairs to the Age Strong Commission. And then they took people, whether you were 50, 60, 103, Irene is 103 years old, and created a whole advertising campaign, billboards all throughout the country, like Irene, who's 103. Senile, you think I'm senile? I play Sudoku every day. I spend time with my boyfriend. I'm many things, and senile is not one of them. So if we can begin to change the language, just as AARP did with Soul Pancake, we don't say, you look good for your age. We just say, you look good. That's our opportunity.
Unbelievably powerful, and Dr. Ye, you bringing up social media and advertising, all just incredibly complex, challenging issues that have the potential to change lives in a positive way. But maybe today, we're experiencing more challenges. I want to take on just one more issue before we get to some concluding remarks, and that's you talked about hearing impairment and hearing loss, Dr. Ye, in your opening remarks. 2/3 of adults age 70 or older experiencing some form of clinical hearing loss. And when you think about that increased risk that you talked about, 10 years of uncorrected hearing loss leading to a 52% increase in dementia, 41% increase in depression, 29% increase in falls, just extraordinary numbers when you think about hearing loss. Well, Bob, we've got an opportunity on Capitol Hill right now that the Congress is considering, the Democrats in particular are considering, to include a hearing benefit in Medicare fee-for-service. This would have a big impact on the Medicare Advantage space as well, and older Americans across the country. Do we think that we're going to get this done? Is this going to be included in a reconciliation package? And if it's not, what other opportunities are there to get at this issue from a policy perspective?
Well, it's intricately tied into the other two. There's only so much you're going to be able to do, and who has a stronger impact. I'm glad that Charlotte brought the hearing issue up, because that may help elevate its standing in the policy and political sense in including it. And I think probably it's going to end up being what's the pay for it on the other side. Are you going to get prescription drug reform done that's going to provide some savings that can help cover the cost of these new benefits? I also think you need to do a real cost benefit piece to this whole thing. What are you going to be saving, as Charlotte said, down the road if you put the benefit in now? I think they're all on shaky ground at the moment. It may be a question of delaying their implementation or limiting it to a certain number of people on Medicare. I hope that's not the way you go. Means testing is not a good way to do business, in my judgment. But I also think that from a internet and Zoom could do a help by stop using the term mute all the time. You're on mute. They should get rid of that term and come up with something better, because I think that has a bad connotation to it.
Mm-hmm. Look, just this has been a terrific dialogue. So appreciative of both of your remarks and your time. 30 seconds or less, just in conclusion, what is the number one thing that advocates in Washington should be focused on in addressing social isolation and loneliness today? What's your recommendation for those listening, for the extraordinary allies and members of the Better Medicare Alliance and those that are participating in today's event? What's your number one recommendation for addressing this issue? Dr. Ye, we'll go to you first.
Well, I think that the most important thing is it affects each and every one of us. It's not about the other group or other people. There is not one of us that isn't human and need that human connection. If you can remember only one thing, I call it my 3 Ps. He said purpose, people, and possibilities. If you have purpose, something gets you up in the morning, something to fight for, and you have people to do it with that support you. Your possibilities, your vision of tomorrow, whether you're 5 years old, 10 years, or 85 years old, become endless. And isn't that what we want out of our lives?
Bob, what's the #1 piece of advice? You get the final word.
For advocates on social isolation, be at every table so that you're not on the table.
With that, I just can't thank you both enough. Dr. Charlotte Yeh, the Chief Medical Officer for AARP Services Incorporated, Bob Blancato, the President of Matz Blancato and Associates in right downtown Washington, D.C. Thank you so much for joining us today and for your terrific remarks.